Chapter 7 basically goes over control of sodium and water excretion. Okay? In regulating salt and water, the kidney is regulating ultimately volume in your bloodstream, which is ultimately going to affect your blood pressure, okay? Which is a big part of it. Okay? So it's really, the blood pressure is a crucial because it's a major signal altering water and sodium excretion by the kidneys. In addition to that, water balance, salt balance, and osmolality is something that the body is sort of measuring all the time. And osmolality is a ratio of solute and water. If you're looking at regulation of blood pressure, your body is basically trying to maintain a set point. Okay? And that set point changes with age. Okay? Most of us in this room that are young, we have a blood pressure in the 120s to 110. Okay? That's most of us. Women tend to have a lower blood pressure. The reason that is because they have lower viscosity in their blood, because they tend to be a little bit more anemic than males. Some of us have the genetic predisposition to be low in hemoglobin, and actually that's an increase in survival for atherosclerotic disease. But most people have a blood pressure around 120 to 130. As you get older, because of our diets in this country, our blood pressure rises because of the changes in compliance of our blood vessels. If you were to be in a healthy environment where you actually were running around and you were doing something very physical all the time, then your blood pressure actually doesn't go up at all. Okay, and there's some people that are very lucky that even at the age of 90, they're not taking antihypertensives. They're still at 110 blood pressure. But also when you look at them, they actually lived a very clean life. Okay? So you have set point. The other thing you have is you have detectors of blood pressure. There's different receptors that will tell the body what the blood pressure should be. One of them, of course, is a carotid baroreceptor. There's aortic baroreceptors as well. But the kidney also is important in the sense of long-term regulation. Okay? The signal that is generated in response to the detectors eventually lead to a signal being sent usually to the brain, and then ultimately that sends out effectors, which changes blood pressure. These effectors will change the smooth muscle contraction of blood vessels or arterioles and cause this blood pressure to rise or fall. If you look at time effects, you can break down this regulation into short, intermediate, and long-term regulation. The one that we're going to have a discussion today, because we've already talked about short and intermediate regulation mostly, especially short-term regulation, is cardiovascular. Okay, that's your classic baroreceptor reflex, which measures cardiac performance and vascular resistance. We're not going to talk about that too much. Instead, we'll talk a little bit more on the intermediate regulation, which are renal sensors of blood pressure that lead to production of chemical agents like renin and angiotensin II, and alters the resistance of the vascular tree as a consequence of that as well. And then you have really long-term regulation, which is due to blood volume. Okay, this is how much fluid your body is going to retain. And so that's kidney. Kidney is ultimately important for long-term regulation. It's regulating the water and salt output to actually alter the volume of fluid within your vascular tree. Okay, that's why when you give people diuretics, you're basically dropping their blood pressure by emptying their volume out of their blood vessels. Okay? That is at a cost, though. Okay, and that's at a serious cost. Yes, it helps by bringing the blood pressure down, but what you do to that individual is you make him functionally dehydrated intravascularly. And as long as they don't encounter a problem like an anesthetic, they do fine. But you're giving them an anesthetic where you preload reduce them, and you vasodilate them, you can really cause them to drop the pressure too much. Okay? And so in those kinds of things, you've got to keep that in the back of your mind. All diuretics are discontinued prior to doing an anesthetic. That's how you should realize that that's not really the safest thing to give to somebody prior to surgery. All right, so here you have this nice mechanism that I've drawn up for you. This shows you that if you have a decrease in blood volume, then you have a decrease in atrial pressures. Okay, these are cardiopulmonary receptors, and they'll send information to the central nervous system in the vasomotor activity centers. The decrease in atrial pressures leads to a decrease in arterial pressure, because what happens as a consequence is you get a decrease in cardiac output. Okay, decreased preload normally decreases cardiac output. What you end up seeing is that you have your renal blood flow is decreased. Okay, as a consequence, the blood going to the kidney activates the renin-angiotensin system. the renin system begins to actively begin to secrete higher levels of renin, which then converts angiotensinogen into angiotensin 1, which then angiotensin 1 eventually causes production of angiotensin 2. Okay? Angiotensin 2 then affects aldosterone by increasing its activity, which then causes more water retention and eventually more water reabsorption. Okay? The other thing that you see is when you have this decrease in atrial pressures and decrease in cardiac output, is that the central nervous system will increase sympathetic activity, okay, which also will increase renin secretion. And what we'll end up doing is that it'll cause an increase in vascular resistance, okay, and that cardiac output may be increased because of this increase in more return in volume. So the system is trying to auto-regulate. It's constantly trying to rebalance itself, and it's trying to do that. So short-term regulation uses the vasomotor centers in the brainstem, set point for blood pressures. The two major detectors are the baroreceptors, which are found in the carotid artery and the aortic arch. Remember we talked about the glossopharyngeal and the vagus nerve being important factors there. And they report the arterial pressure to the vasomotor area. The cardiopulmonary baroreceptors are low-pressure baroreceptors that are measuring blood volume and send information to the vasomotor area as well in the brainstem. Okay? The modulator eventually sends out information from the brainstem to the effectors, which are usually ultimately affecting heart rate, heart contractility, vasoactive tone, which is the arterial blood vessels, and kidney activity. This tends to be a rapidly active system and works at a predetermined set point. So this is the equivalent of the air conditioning analogy that we've talked about before in the back of the room. You have your set point of, say, 74 degrees in here. When it hits 75, the air conditioning turns down. When it hits 73, it stops. Okay? So it tries to maintain this constant mechanism. If you look at the intermediate term regulation, this is still working off the set point, and your sensors are actually found in vascular baroreceptors that are part of the renal sympathetic chain. Okay? They can be activated by beta-1 receptors, and they lead to activation of granular cells to release renin. Okay? So when you cause a sympathetic discharge, okay, or you cause beta-1 activation, you will cause an increase in renin release. Okay? So there is vascular baroreceptors, by far the most important one, but there's also renal sensors as well. What I'm trying to tell you is that if you do a transplant on somebody, blood pressure becomes better if their system is back to being normal. In other words, if you have a new kidney that's actually working like it should, then blood pressure begins to fall, and you have to take these people off the antihypertensive drugs. If, on the other hand, you have a diseased kidney that's producing high levels of renin, then it will not be offset by the transplant sometimes. Sometimes you'll have to remove the kidney in that situation. But most of the time, the kidney transplant takes care of the problem, and usually blood pressure falls within about 3 or 4 weeks. Renal sensors are pressure-sensitive cells within the kidney. They're what's called intrarenal baroreceptors. They sense the afferent arterial pressure. And these cells of the afferent arterial cells have special cells called granular cells, which form part of the juxtaglomerular apparatus. And they really don't send information outside the kidney. Instead, they release a signal protein called renin when activated. So these granular cells are what produce renin. Okay? Renin then has the effect of converting angiotensinogen into angiotensin 1. There's also, besides the intrarenal baroreceptors, you have sodium chloride load detectors. These are osmotic stretch receptors in response to changes in sodium chloride in the thick ascending limb, and they're located also in the macula densa. And so this is a nice picture showing you these specialized cells that are both pressure receptors as well as chemical receptors. So let's give you an example. I'm sorry this didn't come out as well as it should have. Hopefully it's in your notes better. Okay? Let's say you hemorrhage somebody, which happens all the time in the operating room. What happens? Well, when you start hemorrhaging somebody, you get 3 effects, not just one. The first you get is a increased sympathetic to the kidney. Okay, so the neural system begins to sense the blood pressure fall. So usually we'll start increasing cardiac output, increasing tachycardia to try to make up for this difference if it can. Okay. The next thing that happens is intrarenal baroreceptors sense a decrease in pressure. Okay, because they start seeing that the blood flow begins to fall off. And inside in the kidney itself, you start seeing the urine flow dropping down. So the macula densa blood flow is decreased as a consequence. The overall effect of all this stuff, of increased sympathetic discharge, decreased baroreceptor sensing, okay, and decreased macular dense blood flow, is a hyperstimulation of granular cell activation. Each one is a plus sign. Okay? So it causes an amplification effect. Okay? And when you do that, you produce a high amount of renin. So when you have somebody in the operating room, okay, and you hemorrhage them, and that has nothing to do with what we're doing, okay, you will immediately activate the renin-angiotensin system. Okay? And you will cause a tremendous increase in renin release. Now, what will happen in a shock situation if this system is inhibited? Like if you give somebody an angiotensin receptor blocker, an ARB, or you give somebody an ACE inhibitor, then you don't get the response you expect. Okay? And these people don't do the right thing, is in try to protect themselves from this loss in volume fluid. Okay? And they can go into profound shock as a consequence. Ultimately, what you're trying to do with all this normal mechanism is to increase plasma angiotensin II levels. Okay? Remember, plasma angiotensin II levels have two effects, major. It's an arterial vasoconstrictor, and it's also an aldosterone stimulator. Why aldosterone? Because aldosterone increases sodium reabsorption and increases water uptake. Okay, so that person will hopefully hold their water more and hopefully rebalance the situation. What activates renal sensors is pretty simple. Decreased renal arterial pressure or increased sympathetic tone. Either one. Now, what happens if I cut you? What happens? What system gets activated immediately? Sympathetic system, immediately. So no matter what you do, unless you shut the system down, you will get an increased sympathetic tone and you will cause an activation of renal sensors. And as a consequence, everybody post-operatively will begin to retain water. Is that a good thing? No, not necessarily bad, but sometimes it's bad in the sense that somebody has history of congestive heart failure and they retain fluids for 2 to 3 days, and now they're holding not their normal maybe 500. Now they've got 3 or 4 liters in excess in the interstitial space. 3 days post-op, what happens? This system shuts down. Once you suppress the system, then what happens to all that flow of excess fluid? Right, it comes right back in, and when it comes back in, it causes you to have an MI or puts you in a congestive heart failure. The most common day of death after surgery isn't day 1, isn't while you're watching them. You know, we're pretty good at keeping away the dead. Okay? I mean, I've dusted people with enough epinephrine to bring them back from the dead. Okay? Doesn't mean that I'm going to keep them alive. Okay? Because my biggest concern is not so much day number 1, day number 2, it's day number 3. Now, what's really got me concerned is this latest craziness that we're going to be not keeping people in the hospital for very long. Okay? We're moving to pushing patients out more and more out. Okay? And what's going to happen, just mark my words, 5 years from now, there'll be a study coming out that the death rates in the United States are going up post-surgically. And the reason they're going up is because we're not watching the patients in the hospital anymore. They're going to go home and they're going to develop congestive heart failure 3 days post-op because now they're stable, supposedly, and then they're going to get into trouble, and nobody's going to be there to help them. Okay, it's very dangerous. Okay, how many people have seen the patients go out of the ICU, everything's great, and then about 48 hours later, they kind of gets readmitted to the ICU in full-blown failure and dying? I mean, everybody knows that, but how many people understand the mechanism? Now you're beginning to understand the mechanism. This is the mechanism. The mechanism is that this system suppresses your ability to remove fluids, and it begins to hold fluids for a very prolonged period of time, 3 to 4 days. And then when it shuts down, it lets all the fluid return in a hurry back. You know, it's the same system that a horse uses. You ever heard of a racehorse pissing like a racehorse? Never heard that terminology? Okay. What that terminology basically means is when the horse is running full blast, the sympathetic system is cranking up, and it's retaining fluids for that animal. As soon as he stops, his sympathetic system shuts down, and all of a sudden all that fluid that he's retained, it floods back in and he starts urinating like crazy. Okay? The same thing happens in humans, but in a later state. It takes a little bit more time. It takes about 2 to 3 days. So what you see as a consequence of this is that you see decrease in blood volume here. Then leads to a decrease in atrial pressures, which we show that as well. And as a consequence to all this is you increase your sympathetic activity. This leads to a vascular increase in vasoconstriction and increase in cardiac output and contractility normally to increase your blood pressure. That's what you should have. The other thing that it does, though, is it does this. So it increases constriction of renal arteries, and that leads to a decrease in GFR and decreased renal blood flow. And that can be a real problem, okay, in the sense that we can shut down the kidney. The kidney does have a system to protect itself, okay, but you can overwhelm it. If I give you enough epinephrine into your system, your kidney will shut down, okay? Normal processes, once your epi levels hit a certain peak, your kidney is sort of counting how long it can go without blood flow. Once it gets to a certain point, it begins to produce high amounts of prostaglandins, which then inhibit the effects of epinephrine on the renal blood flow, and then renal blood flow opens back up and then reestablishes urine output. But if you inhibit it by giving the person some form of prostaglandin inhibitor, like our friend Toradol, then you can kill the kidney as a consequence. Not that the kidney is being killed by Toradol, it's rather being killed because it's not allowing the inhibitory process to take place to release the renal blood flow and allow for renal perfusion to recur. The messenger that we use for this system, ultimately, when you're talking the intermediate mechanism, is renin. That's a major mechanism. It is a proteolytic enzyme. It converts angiotensinogen into angiotensin 1. Angiotensin 1 then converts it into angiotensin 2 by ACE inside the lung. It's about 95% of it, okay? But sometimes it's found in the kidney, which is about 5%. And it increases vascular tone. The other thing that angiotensin 2 does, besides increase vascular tone, it increases aldosterone secretion. So this is what it does. Hemorrhaging causes increased fluid reabsorption in the proximal tubule. It leads to a decrease in GFR. Ultimately, what you end up seeing is you get an increase in renin secretion, okay? And this causes an increase in plasma angiotensin 2 concentrations. Now, for long-term regulation of blood pressure, you have to change the set point. And the kidney is actually responsible for setting the set point, not the brain. And that's pretty important. So it means if you start getting renal failure, even the brain's working fine, the blood pressure will still normally rise. Okay? So somebody who has anybody that has renal failure tends to become hypertensive. Okay? Now, how did it do with this? That's just ridiculous. I can't believe I wrote that like that. Okay? How does it do this? That's truly bad writing. Okay, that's really funny. I have to shoot myself in the foot later for that one. Okay. What you're doing with this is you're altering blood volume. Is how it's changing the set point. Okay. With long-term renal disease, okay, the person begins to flood themselves over time. They begin to retain excessive amounts of fluid, even though the brain is sort of saying, "Hey, we have too much fluid on board." The kidney is unable to get rid of the free water. And as a consequence, the person begins to flood out. What you end up seeing in long-term players is that they get hypertensive, yes, but they all have peripheral edema, okay? And they also form forms of ascites. They'll actually get cardiac tamponade from this as well, because they'll form pericardial effusions. So it pretty much goes everywhere. This fluid can go into a pleural space. It can form ascites that are not related to liver disease. So it can cause many, many different factors, okay? What you're looking at here is that your sodium and water are not being regulated properly. Normally, the kidney regulates volume by regulating extracellular fluid osmolarity or total osmotic content. Okay? About 90% of the extracellular fluid osmotic content is accounted for by sodium and the equal number of anions. So when you look at this, sodium content times 2 is equal to normally your extracellular osmotic content. What happens over time is that in these kind of diseases is that you get pressure natriuresis and diuresis. If pressure is elevated, the body thinks there is too much sodium, so it releases it, which causes a natriuretic factor. So too much pressure is also releases water, which causes what's called a pressure diuresis. What I'm trying to show you here with this picture is that the increase in blood pressure leads to an increase in the afferent arterial pressure, which of course that usually will increase your glomerulocapillary hydrostatic pressure, which then causes your GFR to increase. Okay? Now, the other thing that will happen is that it'll usually decrease renin production, okay, because it'll, and as a consequence, decrease in your renal angiotensin II production. As you increase your glomerulocapillary hydrostatic pressure, you should increase peritubular capillary pressure, which then causes an increase in renal interstitial pressure, which eventually ends up excreting larger amounts of water and salt. That's the normal mechanism. In disease, that doesn't work out. Okay, the kidney is unable to do that and begins to accumulate fluid as a consequence. So ultimately, the body is trying to control GFR. It's a reflex control mediated by afferent and your efferent arterial resistance. And the changes of resistance are a result of sympathetic nervous system. Notice one thing, what's missing in here? There is no parasympathetics. Parasympathetics do not affect afferent and efferent arterial control. It's purely sympathetic. So if I give you atropine, am I going to reverse the effects of afferent and efferent arterial vasoconstriction? Absolutely not. Okay? Angiotensin II, ANP, and ADH are also factors that alter GFR, okay, by altering this resistance. The tubulo-glomerular feedback and autoregulation system is pretty important in the sense that the kidney is constantly sensing the quality of the urine. Okay? The mechanism for autoregulation of GFRs involves local production of prostaglandins, which when you over-constrict the area too long, you get prostaglandin production increases, which leads to relaxation and vasodilation of mesangial cells, which eventually increases the glomerular blood flow back, and then you get more filtration. Without the prostaglandins, you lose the ability to vasodilate the renal vasculature, and as a consequence, you can actually inhibit so much of the blood flow to the kidney, then you can put the person into renal failure. Now, this is a classic example of this, and you really need to pay attention to me. Toradol is a great agent, as long as you understand one thing. You never give it to somebody in shock. Period. They had a patient that was done at the other hospital that came in to us about 3 days later because they're in profound renal failure. And the guy had just had a simple appendectomy. Okay? When he came, he went to the other site. They noticed that his heart rate was 130 and his blood pressure after induction was 95 over 72. What does that tell you? 95 over 72 should be bringing alarms in your head. Blood pressure seems to be okay, right? But it's not. This is a young person. He's 36 years, he's like 26 years old. Okay? He's vasoconstricting like this. Okay? He's maintaining a very narrow pulse pressure. The pulse pressure in a young person should be 60. So if his blood pressure, his diastolic should be 60, he should be at 120. What he's done is his body's done this with his volume. And he's squeezed the arterioles as hard as he can to maintain the blood pressure. And he's telling you that he's in shock because his heart rate is 130. So this guy was in profound shock. Okay? And what they did, instead of giving him fluids and rehydrating and getting back to where he needed to be, they decided, well, you know, he's fine, he's a young guy, we'll give him Toradol. 30 milligrams of Toradol IV. Well, the next day his creatinine went from 1 to 4. That's a little bit of a problem. Okay? He went into full-minute renal failure almost. Okay? The good thing is eventually he did get it back because when he got sent to us, we rehydrated and we put in 4.5 liters of crystalloid in this guy. Okay? He went from a hemoglobin of 14 down to 8. So he had hemorrhaged too into this appendix. So that's one thing that it said they lost about 2 liters of blood and they couldn't see why the concentrating effect. I don't know whether they must have just missed the ball. Okay. So make sure that if you have somebody who's in profound shock, do not give Toradol, okay, because you inhibit this prostaglandin synthesis production, okay, and you will put the patient into failure. So angiotensin II production is important for, actually this is not that important. I'm going to keep moving on. What I want you to sort of understand is here is the peritubular capillary starting pressure and the renal interstitial hydraulic pressure. Is that when you're looking at the vasa recta when they're returning, okay, they're very important to reuptake water in the upper portion in the peritubular capillary. This is the vasa recta, okay, and that's all they're really trying to show you here. Now, ultimately, the control of sodium balance, let's get back to that, is through aldosterone, okay. So if somebody asks you, well, how do you regulate water balance? ADH is by far the most important, okay. How do you regulate sodium balance? The answer is aldosterone. Okay? Aldosterone is the primary hormone that regulates your sodium content. Okay? Now, does ADH also control water sodium content? Yeah, it does. But the primary mechanism is aldosterone. Okay? Remember that aldosterone is a it's a hormone produced at the cortex of the adrenal gland. Okay? So it's a corticotropic hormone in a sense. Okay? What it basically does is it increases sodium reabsorption in the connecting tubules and the collecting ducts. And their major effector which activates its release is angiotensin II. The other thing that also will increase levels of aldosterone will be ACTH. The other thing that will increase levels of aldosterone will be sympathetic outflow and low sodium levels. Those will all activate an increase in secretion of aldosterone. What you see as a consequence is that when you get increased levels of angiotensin II, it does two things. Well, increasing angiotensin II increases your aldosterone secretion. What also increases your aldosterone secretion is increased potassium and increased ACTH. Okay, what's also not in here is an increase in decreased sodium concentration. Will also eventually cause aldosterone secretion to be increased. And as a consequence to this is that you'll cause plasma aldosterone to increase. If you cause somebody to hemorrhage into their adrenal gland, which can happen, okay? Shock states, profound, some forms of meningitis, attack the adrenal gland and kill it. Okay, you can hemorrhage into the adrenal, and you can lose the release of sodium. And what happens in that individual is now they won't retain sodium. So what will happen to their urine? If you lose aldosterone, what happens to your urine? Does it dilute or concentrate? It dilutes. If you can't pull sodium back into the kidney and back into the blood vessels, in other words, if you're not pulling it in with aldosterone, then the sodium stays in the urine. And what happens to the water? Water stays where salt is. So you begin to form a very dilute urine as a consequence. Okay? So people like that will all of a sudden begin to diurese massively on you. The way you pick up on it clinically, although I've seen it only once in my career, both the people that I did see, they died. Okay? Because most people don't survive adrenal hemorrhaging bilaterally from some form of infection like this. The control of aldosterone secretion is the main mechanism for sodium balance. The adrenal stimulation occurs via an increase in plasma potassium concentration or angiotensin II. And things that inhibit aldosterone production is atrionatritic factor or atrionatritic peptide. Okay? So this is, again, a little bit of a visual way of looking at it. Okay? Low sodium diet causes a decrease in blood pressure. The kidney gets an increase in renin secretion, and then as a consequence you get an increase in angiotensin II. Increased ACTH or increase in potassium concentration leads to the adrenal secreting an increase in aldosterone secretion, eventually leading to an increased tubular sodium reabsorption. Other mechanisms for controlling sodium balance are the natriuretic peptides and antidiuretic hormones. But these are minor in comparison. Okay? If I if I give you an increased level of ADH, what happens to my sodium content in my bloodstream? It falls, okay? Because I put more water back into the system. Okay, it's antidiuretic. If I give you a natriuretic peptide, okay, what does that mean? It means I diurese that person, okay? I sodium waste that person, okay? And then I will actually get a more concentrated, more dilute urine and a more concentrated blood concentration of sodium a lot of times. So natriuretic, okay? Or it balances. Either way, the volume drops off in these kind of situations. This is where the action's taking place. Okay, this is a picture showing well, aldosterone is working. Okay, it works by inhibiting it actually increases sodium reuptake of sodium through channels, and eventually causes an activation of the sodium-potassium pump, which then helps pull sodium out. At the same time that's pulling the sodium out, what's it doing? It's also helping waste potassium out. Okay, so normally when you increase aldosterone levels, you tend to waste potassium and increase your sodium. If you look at control water excretion is equal to water filtered minus water reabsorbed. The baroreceptor control is the ADH secretion, and osmolar receptor control of ADH secretion is also important. And ultimately, thirst and salt appetite also is part of the whole mechanism, which is part of your brain.